and ask yourself, can we give that patient a chance? And make sure that you developed an institutional protocol, because it's not just from the ED, has to be continued upstairs in the ICU.
Welcome to Velocity from Vapotherm. Dr. David Farcy is chairman of emergency medicine at one of Florida's largest hospitals and president of the American Association of Emergency Medicine. In today's episode of Velocity, we join a conversation with our own director of ED education, Dr. Kirk Hinkley, and Dr. David Farcy to discuss his COVID-19 experiences and how the hospital has been using Vapotherm high-velocity therapy. Vapotherm high-velocity therapy is a tool for treating respiratory distress. Vapotherm does not practice medicine or provide medical service or advice. For any devices mentioned in this interview, please refer to the instructions of use before use. Now, let's join Dr. Hinkley and Dr. Farcy.
Start with telling us about how things went in South Florida. I know you guys were one of the busiest areas in the country with COVID. So if you want to just tell us about your experience, your hospital's experience.
I'll tell you a little bit about our, in South Florida, about end of February, early March, we started noticing that we had an influx of COVID patients. And as we were preparing and gearing up by March 16, we started realizing that our ICUs were full. We had to open a new ICU and we're running out of equipment to a point where in March 16th and 17, I found myself in my respiratory department going and discussing with them, how can we hook up one vent for two patients? And, I was actually really contemplating maybe we're going to have to start using a vent for multiple patients. And I know this was not ideal. We did multiple tests. And then I started reaching out and calling, and friends of mine all over the country, New York and Italy and Europe. And I'm saying, why can we not use high-flow oxygen? And especially in our institution, we have Vapotherm. And people are saying, you know what, listen, we're using everything. We're trying to avoid intubation, because once we intubate them, it's the patient doesn't generally tend to do well. And about the same time, Professor Gattinoni out of Italy released a editorial that was on March 20th, who said that COVID was not the typical ARDS type of patient that we saw, that they have such a very large compliance, and it's really not the ARDS, really difficult to ventilate using lung protective, 4 to 6 cc's per kg, and then really titrating the PEEP. And his recommendation was limit the PEEP and actually check what type of patient you have. And this is when we first started to say, you know what, something is different. And one day I had a patient who in his mid-70s now, I'm in South Florida, mid-70s are pretty young patients, who, when I looked at him, was sitting in his 70s, like 70. And the guy just was like, listen, I just want to go home. And, I found myself having an argument with this patient saying, how can you go home? And I was questioning myself and saying, how can this guy make a decision? We know any emergency physician in the country know that at 70, this is causing severe hypoxia, and the patient probably doesn't have the capacity to make decision. But as I'm arguing with this patient starting making more sense, and I just said, you know what, something is wrong. And when I found out that the patient didn't want to be admitted, wanted to go AMA because he was fearful of being intubated. And so this is kind of our first patient that we put on high-flow nasal cannula, especially the Vapotherm, and we use a mask. And then the more and more I started asking around the country, the more and more people were saying this is the way to go. And we kind of did some interviews, we did several podcasts, and we really realized that the term that the ambulance, the EMS coined hypoxic, was we were really seeing people severely hypoxic and walking alert. And those patients would decided to say, you know what, we're not going to do what the guideline or the recommendation all over Europe said. We're not going to rush to intubate them. We're going to give them a chance and see if we can try to bridge them or maybe help them. And in doing so at the time, we noticed that when the patient shifted position themselves, right, their oxygen saturation would go up. I had a patient who got up and said, hey, can I go use the bathroom? And I'm like, and his O2 sat went from 90 to 98. And so we started having the patient kind of doing awake proning. And the more we did, the better the results we were having. And so as a chairman of a big department of emergency medicine, before you do anything, you have to make sure that it's safe, right? So we had to educate. And what was more important from my point of view, I'm kind of a hybrid, I'm double, so I'm emergency medicine, I'm also critical care. So I wanted to make sure my team upstairs would be on board, because I don't want to do anything in ED, and then as soon as they get to the ICU, they would get intubated. And so we had the buy-in of several of our ICU doctors, and we started doing this. And at that day, we had 2 vents left. And I can tell you that was one of the turn for us, because after this, more and more, we had more vents. We're really using the vent for the patient that failed this therapy or needed it. This is not for every patient. If the patient is unable to follow command, is altered, is confused, we're definitely not doing this. But if they follow command and they're able to prone and they were able to follow command, we did it. And I know this is a observation of one, but right now we are collecting some data retrospectively, and as we finish collecting our data, we'll let our data speak for itself.
Yeah. Now, how about, you mentioned, letting people fly on Vapotherm on the Highflow. Are you using any type of objective measures to measure those failures, or are you using clinical indicators to know if people need to go on to intubation?
So that's a extremely difficult question to answer, because when you see those patients, they're all tachypnic, right, in the rate of 30s, 40s, right? They're all tachycardic, but they're maintaining a blood pressure. If their lactate are elevated, it's not drastically elevated. All of them had procalcitonin less than 1. We kind of use procalcitonin in the ED measure to see whether this was the viral part or a bacterial. But really, it was really guided by the mental status of the patient and not by the number. And it took significant amount of education, because a couple of things that we've noticed, if the patient is not taught and he's not explained that you have to hold your high flow when you move, we noticed a couple of times that the patient, by accident, it would fell off their face, and then suddenly you see O2 sat in the 30s, 40s, and people rush to intubate. But if you put it back on a patient, they get back to 90s or low 80, high 80s, low 90s, and it works.
Now, were you able to influence some of the major societies in determining what their guidelines or recommendations were going to be? Certainly you had some of the first or earliest experience with COVID. So did you work with Society of Critical Care Medicine or CDC or anyone like that to help them really change the direction that they were going in terms of their guidelines?
We try to get the word out to several of the societies, and people were not really listening to us. It was a group of 4 of us who did a podcast on Rebel EM, that then the American Academy of Emergency Medicine used that podcast, and pretty much to say that don't rush to intubate. At the time, the data on intubation was survival was, 88% mortality rate, depending on what country and where you were. And I think it was very difficult for people to make guidelines because there was no evidence. And the evidence comes from SARS and MERS and Ebola, where people said, when a patient crash, you have to be careful in intubating because it's it's a difficult intubation because you're wearing all this protection and the airway is edematous, which we never really saw the edematous airway, but we did every patient that we intubated that failed, we had nobody crashing and nobody dying from the intubation.
Yeah. So since your early transition to Vapotherm and Highflow, have you continued with that trend? I mean, obviously you've been able to keep people off ventilators. Did your successes continue? And were those therapies continued in the ICU setting or on the floor setting, or if you cohorted those patients in some way?
So yes, it was definitely continued. Not only continued, but as the days and week started passing, there was more and more buy-in from our intensivists, from our pulmonologists, and now we're using it more and more to a point where actually our hospital bought a lot more Vapotherm, so we can deal with a larger population.
Mm-hmm. Have you used any positive pressure, non-invasive, like BiPAP, CPAP at all in the care of these patients?
So there's been so much talk about using non-invasive BiPAP and CPAP. Unfortunately, we didn't have the helmet to use, and it was felt that there was too high risk, and that was a much more difficult conversation where people were not really willing to listen. One of the great things about the Highflow and Vapotherm, we were able to show to our pulmonologists and to our staff that if you put the Vapotherm with a facial mask, that the spread of the virus is almost negligible. And so that study, I believe, was in chest. And once we showed the images of Vapotherm without a face mask and Vapotherm with a mask, and there's almost no spread of the virus, that showed a significant higher level of comfort from our staff. But when you look at the data on CPAP and BiPAP, unless you're using a helmet, the data is very limited on the spread.
Sure. Now, you mentioned Professor Gattinoni. One of the things that I question about his L subtype is the ability to recruit. And he said, hey, these are not ARDS lungs. They're really not recruitable lungs, but yet we're seeing benefits to proning strategies and positioning in these patients. What do you think about that?
I definitely agree with Professor Gattinoni. There is no recruitment in this disease. I think the proning, what we're doing with the proning is we're really changing the VQ, and we're just changing the flow. So when the blood goes down, the oxygen level will reinflate the alveoli, but it's not true recruitment. The process of this disease is shown to be more a venous vasoconstriction, and it's just really to promote oxygenation. It's not lung recruitment because, like I said, the moment they come off of it, they desat like almost immediately. And that's why we don't really think this is a recruitment.
I gotcha. Now, are you using any pulmonary vasodilators as you know, before intubation as ways to kind of stave off intubation?
Like, I'm sorry, like?
Pulmonary, like nitric oxide,
Uh,
Flowlan, anything
so,
like that?
we're not using Flowland, but we are using nitric oxide, and we had I don't want to say success, but we had several positive cases. The problem with the nitric oxide, we had limited resource with the nitric oxide.
Gotcha. How about remdesivir or any of the we'll say study pharmaceuticals?
I can tell you that if you name a drug, you name a modality or therapy, we've done it all. From remdesivir, from convalescent serum, to lots of different other modality. I'm not in liberty right now to discuss any of these because we have some ongoing trial right now, and not the principal investigator on those trial, and so I'm not gonna speak pro or against.
Sure.
Any of those, but we did try a lot of those therapy. We had patients on ECMO. We've tried everything we can. We were one of the busiest hospital with the most case in the state of Florida.
I got you. Now, for those patients that were intubated, have you been able to extubate people first of all, and then for those of them that were you able to use Vapotherm as a extubation strategy or to help these people fly once they came off the vent?
For some of the patients that we extubated, we do have a protocol in place in our institution that we extubate to Highflow, Vapotherm, or extubate to BiPAP or CPAP. In these patients who needed a higher FiO2, we used Highflow Vapotherm once we extubated them.
Now, as we move forward and you guys are trending out of what I hope is your peak or your surge, what do you see as maybe a transition in the way that we approach respiratory patients or infectious patients with treatment modalities like Vapotherm? Are we going to see more high flow therapies? Are we going to see more Vapotherm as we, in our COPDers, our CHFers, as we approach any suspected infectious patient from here on out, as we know that we'll have some lingering COVID or God forbid the next infectious disease to come down the pipe?
Well, I want to say I hope so, and I think so. When I started training 20 years ago, in the era where we're talking about pulmonary edema patient who came in acute respiratory distress, and all those patients back then we used to rush to intubate them, and it took several years for people to buy in with non-invasive as a mean of giving time for the therapy to bridge those patients. And today, those acute pulmonary edema, a large number of them are able to be safe on intubation. So I think that Vapotherm has a definite role now in the algorithmic of respiratory difficulty. And I think there's going to be a lot more data that's going to need that in epidemiology or pandemic future disease. We need to realize that we need to trust our PPEs if we have PPEs. I'm proud to say that none of us in our institution got infected. So we did well, and we also have to trust our skills. And so I don't think that rush of we need to rush to intubate the patient because of risk of contamination. I think that's something we need to look at and review, because mechanical ventilation is a great modality for patient that has failed, or if they're going to go for invasive procedures. but to rush to do it in certain patients, there's also, we know all the problems with trauma, shear traumas, trally, and it does cause some phenomenon. And in this COVID disease, we don't know what it does yet, but this is something that has changed everything that I've ever seen, heard, or even taught. I mean, if once you see it, it's hard to believe.
Yeah. Now, you mentioned PPE and taking precautions. Are you doing anything special in terms of your staff or cohorting or negative pressure when you are using Vapotherm on these patients?
So it's, I don't know about most institutions in the country, but from looking at some of the data in New York and ours and some of the data across the world, the negative pressure rooms were very limited. And in our institution, we made a decision to have a COVID emergency department all by itself, where we put all the person under investigation into that one 30-bed department that was just COVID, and all staff worked the entire shift with their set of PPE. If they, were contaminated with blood or liquid, then they changed their mask as needed. But we didn't have. I mean, we did the Vapotherm. We did it on any room, any place we had it. That with the mask, because again, that study really shows there's very little spread of the virus.
Gotcha. So as we get closer to wrapping up here, is there any lessons in particular that you have for your colleagues that might not have had the early experience with COVID that you have?
I know that for the past 12 weeks, when we first said this, everybody said they want to see evidence that this is just an observation, and we know that observation is not real science, and everybody wants double-blind, controlled, randomized trial. I can tell you that it's very, very difficult. We filed the IRB for our retrospective, and now we're going to do a prospective. It took 3 weeks to get the IRB, and that was expedited. And the evidence will come. But again, it's going to be, you got to see, once you see those patients, and it's every inch of you is going to want to say, we need to intubate. And I think if the message, if anybody listens to this and they haven't seen as many COVID and their area starts seeing some COVID, just take a step back and look at your patient and say, just remember one thing. If your patient is alert and O2 side is 60, respiratory rate of 40, and you put them on a high flow oxygen, start at 40 liters, put it on 100%, put a face mask, and if suddenly their O2 sat goes back after 20 minutes to 100, and you're able to start titrating, and they're able to sit, and ask yourself, can we give that patient a chance? And make sure that you developed an institutional protocol, because it's not just from the ED, has to be continued upstairs in the ICU.
Great. So I want to thank you for being an excellent ambassador for emergency medicine. I know you do great work at the AAEM, and you've done great work in helping further our knowledge with COVID. But do you have any last minute comments before we wrap up?
I just want to commend all emergency physicians, because we've been on the front line of this disease, and our volume went skyrocketed, and now we're facing another challenge that the volume now has plummeted down, and you're facing hour cuts, and you're facing financial challenges. And I just want everybody to be thinking positive, and we will survive this, and things will return back to normal. and please be safe. And the last thing is there is no such thing as an emergency in pandemic. Don your PPE and be safe.
Thank you so much. And if you need anything, let us know and we'll try to help you out.
All right. Thank you very much.
All right.
Very much.
Our collective understanding has changed greatly since the start of the pandemic. As more clinical data becomes available, we're hopeful COVID-19 patient care and outcomes will continue to improve. Speaking how that care has shifted, our own John Walsh has a fantastic on-demand presentation available now at Vapotherm Academy. COVID-19 patients on high-velocity nasal insufflation discusses clinical research, transmission risk, and proper protective measures to help reduce transmission risk when employing high-velocity therapy. For nurses and RTs listening, the course also qualifies as 1 contact hour or 1 CEU under the clinical practice category. You can find that on-demand course and many others at academy.vapotherm.com. It's the web address academy.vapotherm.com for Vapotherm Academy. Thank you for joining us on this episode of Velocity from Vapotherm. New episodes are released periodically, so whether you're listening to this on Apple Podcasts, Google Podcasts, Stitcher, YouTube, wherever you are, please be sure to hit that subscribe button so that you never miss an episode moving forward. Thank you for joining us for this episode, and thank you for everything you do.